A very good afternoon to everyone. Today, the topic of discussion is future of digital pathology. So, pathology has been there for a long time, and so just like our smartphones, which have first generation, second generation, like this pathology also has its own generation. So, the first generation was the use of traditional microscopes. Your second generation is your digital pathology, which we'll be talking about today, and the third generation is your artificial intelligence. We'll be talking about what is digital pathology, about whole slide imaging, what is telepathology, uses and validation of digital pathology, and artificial intelligence. So digital pathology is not a new concept. It is present since around 40, 50 years roughly around. It started with the use of using computers in hospitals and pathology also. And in 1986, it was the first time they introduced telepathology. And roughly in 2000, there was formation of Digital Pathology Association. And more recently in 2018-20, Philips is the only one who received FDA approval in the field of digital pathology for whole slide scanning. And though it is not related to our topic of discussion, but IDX-DR, which is the first and only medical device in the field of artificial intelligence to get a FDA approval for to detect diabetic retinopathy. Next, we'll be talking about what is digital pathology. It is an acquisition, management, sharing, and interpretation of glass slides and data, everything in a digital environment. So right now, all our reports are online. But what we mean is we have our slides also online. We interpret those online slides, and we give our report. So we have this tissue slide or HP slide or a glass slides which are made from your histopath block. So this slide we will scan using a whole slide scanner and we'll get a whole slide image. And this image we can view it on a computer or a mobile phone. Next, we'll be talking about the four key components of any digital pathology system. Is you should be able to capture the image of your histopath slide. Second, you should be able to store and archive that image. Third, you should be able to edit, in the sense you should be able to zoom in, zoom out, you should be able to mark, annotate those areas. And fourth is you should be able to view and share these images with your clinicians, your fellow pathologists, or even your patients. So we'll be coming to what is digital image acquisition system. It is nothing but your first component, which is to capture images. So what do we have in capture images? First is to have something as basic as having a microscope with a digital camera attached to it. Next is whole slide scanners. We'll be talking about this in detail. Third is your robotic microscopes. Now, what has come a recent update, it is developed by MIT. So they scan, what they do is they make a 3D model of the organ directly from a histopath block. So what they do here is that this is known as a knife edge scanning microscope. So you have a diamond knife over here which takes serial sections of your histopath block, and right in front of it there is a objective with a line scanning camera. So it captures image of every section that goes by, and that's how they prepare every image. Every layer is prepared of your organ, and you can get your whole 3D image of your histopath block. Next, this is the digital image acquisition system in our institute. This is a Zeiss Axial Lab microscope, which is connected to a television set where you can view it for broader viewing. Next, we have a Leica, which is attached to our computer's screen. And third is a Silica, which is a microscope, which is attached to a tablet. Next, we'll be coming on to whole slide imaging. So whole slide imaging or whole slide scanners that are used, these are the heart of your digital pathology. It is the most dynamic application of technology to pathology. And this is nothing but a microscope with a robot under robotic and computer control. So this is the Philips version of the one which is approved. So it has around 300 slide capacity to scan, and it scans around 60 slides per hour. So it has a load, and it has a facility to load these slides, and there is automatic scanning of these slides in this under here. So before loading in your slides, some hospitals have their own SOPs as to how the slides should be. So some of them prefer that the slide sections are taken very thin sections to get a beautiful image. Second, it should be a 15 by 15 of tissue which should be on the slide. The slides should be dry. There should be no oil or marker on the cover slip present. And your slides should be a standard, which is your 75 by 25 or your double width wide slides, which is your 50 by 75 slides. And the slides should be barcoded at one end with your patient ID, your case number or your slide number, and the stain that is used for that tissue section. Next, this BSI devices have a microscope objective lenses, which are either 20x or 40x lenses. Now, there are new scanners that are coming in the market, which are even 100x oil immersion also. Then your scan resolution. Your resolution is nothing but your sharpness, where the two image, you have an ability to separate two images. So for a 20x, it is 0.5 microns per pixel. Pixel is nothing but picture element. So image in each pixel should have a square side of 0.5 microns for a 20x and 0.25 microns for a 40x to get a clear picture. Then some of the scanners have a digital zoom technology where you can increase the magnification of these slides of your slide. Next is your scan plan. So this VSI devices all have their own scan plan, in the sense how they the focal plane of the objective keeps moving. So some scanners, they scan the entire slide, which is your tissue along with this empty parts, the entire slide. What happens in this is your data increases and the time to scan increases. So there are other scanners which what they do is they automatically detect your tissue and they scan only the tissue. But this can create a problem, especially in your biopsy where you have biopsy fragments. So it will not capture the small ones. So there is a feature called as bounding box where you create a box and it scans everything inside the box, that is your tissue as well as the empty parts inside this block. Next is your out of focus area. What happens is when your slides, which you have put in scanning, have tissue folds on it, ink, your dust, marker pen over the cover slip, air bubbles, it doesn't scan properly. What happens is that you have your slide, you have your tissue, you have your cover slip. It starts focusing above the cover slip and doesn't focus on your tissue. Now, there are some scanners that help you choose which one you want to choose. You can choose the marker or you can choose the tissue. So you can select the tissue and it will focus on that. But if you don't have that facility, it will result in an out of focus areas. Now, to compact this out of focus area, there's a new feature called as Z stacking. So now when you move your, in your traditional microscopes, when you move your stage, you basically move them in your X and your Y axis. But there is a third axis, which is your Z axis, which bisects through it. So that axis is used as the Z stack. So basically what it does, it scans at every level. If there is a tissue fold also, it will scan at every level of the tissue fold. So you will be able to see cells in every fold of the tissue section. So you don't have to give a recut or, redo the slide and then scan it. You can scan it even though if there is fold on it. The only disadvantage is that it increases the scan time and the amount of data. So as the SOPs are there, to have a good section, good slide is important. Next is stitching. So how do these make a whole slide image as we see? It captures continuous images either in tiles. So it goes scanning tile by tile and then it starts stitching these. Or it takes entire strip. The entire strip is scanned and then they stitch it. This is how a whole slide image is then created. Next is once you have captured the images, you want to view these images. So you need an image viewing display. So the display should have a good resolution, brightness, color, contrast. Now some of the displays that have come in have also additional tools which will help in help in diagnosing or using them in our reports. So basically they have these areas to mark or annotate. Then they have areas where you can measure the you can measure the length of the tissue, or you want to measure meds or something. You have those tools added in these. Next is after you have captured images, you have viewed them, you want to store them. But the problem with storing is there's a large amount of data and you need to compress your image. So there are two types of compression that you can have. One is your lossy and your lossless. So lossless means nothing, but there is no loss of original data. So what happens is when your original image is compressed, there is some amount of loss in clarity or the resolution. So that what happens in a lossy. So in lossless, what happens is when you compress the image, there's no loss of the original data, and you can always go back to the original image. Whereas in lossy, it is exactly opposite, that you cannot go back to the original image and there's a loss in data, that is, if there's image loss in the sense of resolution or quality. So ideally, we would prefer a lossless image where the original image is not lost, and we can have the compressed image also and will not have a image loss. So what we use is your JPEG, your TIFF and your JPEG 2000, which I use. And these images, they are stored as an image pyramid. So whenever you see these images, they have a low scan, then 20x, and then 40x. They are stored as a image tiles. Next, what is the advantages and disadvantages of your glass slide and your virtual slides? In glass slides, we already have an infrastructure. We need only the skill to develop or skill to practice. Whereas virtual slides, these are accessible to us anywhere, anytime. So it is a faculty time saver. You can annotate these areas, and rare features, you can view them again. We can view them in group or individual. And computer interface is much less intimidating for everyone. Disadvantages of your glass slides is it is more faculty time intensive. Everyone has to come to the department and view through the traditional microscopes all the slides. Your slide have to be maintained, your slide papers and your slides have to be kept in order. Then it is student time demanding. There's a microscope learning curve for everybody, and physical storage is a main issue with slides, with the traditional glass slides. And disadvantage of your virtual slides is we have to invest a lot in software and equipment. Diminished faculty contact. We have to motivate our faculty, our technicians, and everyone to move towards digital pathology for acceptance. Next is we have a file compatibility and viewership issues, and device and network speed. So basically, to have a digital pathology in your institute, you need to have at least three things. One is a very strong IT backup, very strong IT support. You should have a backup, and you should have an expandable storage. Next, what is the concordance rate between your light microscopy and VSI? So it's around 95% for a GI pathology, 94% for dermat, and 93 for breast, and 95 to 97 for mixed. These are the vendors which actually sell whole slide scanners. So we have 3D Histotech panoramic version. There's panoramic 1000, which has a 1000 slide capacity to scan. Then is your Digipath Pathscope, Hamamatsu's Nanozoomer, and Leica Scan Scope, and your Philips Ultrafast Scanner. These are the whole slide scanners in our institute, which is Morpheus Continuum 48 and Optimus 60. So if you can see here, you can see here there is you can see a microscope objective with a light source, and here are your slides that are scanned, and you can view the image on our desktop. Next, we'll be coming out to what is telepathology. Telepathology is nothing like telemedicine, which has come up right in COVID times. So it's just a pathology service component of digital pathology, and it is performed by pathologists at distance. It is very helpful for those areas or remote institutes which don't have a pathologist. You can do even with experienced technician. So it was started by Ronald Weinstein. He's known as a pioneer in telepathology. He's the most famous pathologist. He started it between a clinic in Logan Airport and his hospitals. And he's also credited with the term, he also coined the term telepathology, and in some institutes also regarded as the father of telepathology. So what does CAP define telepathology as? It says it is a practice of pathology in which the pathologist views all digitalized slides and gives an interpretation on those, and they include it in their formal diagnostic report. So now in telepathology, there are two people involved. One is your telepathologist, And next is your referring pathologist, or if there is no pathologist, there is a experienced technician. There are two types of telepathology, which is your static and store forward, and the next is your dynamic telepathology. So what happens in static is your referring pathologist, he captures and clicks images on his microscopes and sends those captured images to your telepathologist. The problem with this is that whoever is the referring pathologist should have an idea of what area to capture and send for interpretation. So that's one of the disadvantages. He should have a knowledge and experience to capture it, and the clarity should be good. Advantages is that this is that it is low cost. It is very simple to use, simple to small files are manageable files, and system is easy to maintain. Next is your dynamic. So the problem that occurred with static is compacted by the dynamic version of your dynamic telepathology, in which the referring pathologist transmit live images from your microscope or your macroscope platform to the telepathologist. So it is by a standard microscope with the referring pathologist with a digital camera attached, or to the telepathologist who has a robotic microscope with him. The advantage is that there is a real-time transmission, so the telepathologist can view the entire slide. He can ask for certain areas to be focused on, and there is up and down focusing is possible. Disadvantages is the technician is required or someone is required, and higher bandwidth is required, and post navigating and focusing requires some expertise. Now uses this can be used in intraoperative consultations. This can be also telepathology can be also used for macroscopy, especially in remote areas, for gross pathology, especially in remote areas where there are no pathologists. So you can send images of your grossing while grossing is being done, or you teleconference with the operating surgeon. Next is your telecytology, where you transmit cytology images. And lastly, a new concept, which is teleautopsy, wherein you send in external examination and organ macroscopic examination to the telepathologist if you don't have an experienced staff pathologist with you, without having to move your to the PM room, or without having to transfer the body from one institute to the other institute. Next, we'll be coming up to the uses and validation of digital pathology. Uses, it can be used in consultation, as we discussed, for your daily case reporting. You can use it for your intra-op consultation. You can use for second opinion, in cases of second opinion, expert opinion. You can also use this, especially in COVID times, been used for work from home pathology. Then next is your education. You can use this education, this VSI devices have been used to create a virtual slide box, just like the slide box that we have. It was started by Dr. Fred D in University of Iowa. Also, University of Michigan has their own website where they have each organ system wise on the website. And you can use it for CMEs, conference, multidisciplinary tumor boards, and your clinical pathological conferences. You can use this for archiving your slides, where you require most glass slides require more storage area. So you can use this to archive your slides. And especially in those cases where we have biopsy, we have only one slide, we can scan those and keep with us, and we can give the slide to the patient. Advanced image analysis, we can use this software of theirs to quantify ER, PR, and HER2/neu. And we can also use this for advanced studies, like to know the tumor percentage of tumor and glands stromas that is present. And for medical research also, we can use this digital pathology. Next, coming to validation of digital pathology. If you want to start a digital pathology in your institute, you should have this validation system in place. And this is the RCPath guidelines of best practice recommendations for implementing digital pathology. So it starts with having basic learning skills training. Second is to learn to diagnose it digitally and also with glass slide, and compare it with glasses. Second is to have stage 1, which is your validation training set, where you go retrospective 20 cases and use that as a test set. Second is to have a validation live cases, where you go prospective as the cases come, prospective for 3 months. You do your digital as well as your glass slides. And next is you give a validation statement and you go for ongoing monitoring. So these are the samples for your stage 1, which is your retrospective 20 cases. So whatever case comes, you give a digital diagnosis. What is your confidence at that digital diagnosis, and then your glass diagnosis and your confidence level at that glass diagnosis. Second is your live as prospective for the next 3 months. So you give your digital glass diagnosis, and then you give your preferred diagnosis, and also in any discrepancy in both the glass and digital diagnosis. And this is the final validation statement that you give at the end of the period. Now, coming on to the third generation, that is your artificial intelligence. So, artificial intelligence means nothing but it is mimicking your human intelligence. So, what we need is a long-term goal of reaching general intelligence, which is your strong AI. Now, your Alexa, Siri, Cortana, these all are your weak AI, where they solve only one problem at a time. If you ask them to play a song, they'll play you a song. So, that is a weak kind of AI, and we need a strong AI, which is your machine learning and your deep learning. So deep learning is a subset of machine learning, and in deep learning, it's a neural network system where you feed in the data of numerous data, and they learn from that data, and they find hidden patterns in it, and they're able to diagnose. And this deep learning was used in Gleason grade. So. And next is your machine learning. Machine learning, it automatically learns from the data that it is exposed to. There could be pathologists need support by AI. We can use it to differentiate tissue types from malignant to non-malignant, invasive, non-invasive. It has been used to detect metastasis in lymph node. The main task would be to use it as a screening for detection of small tumor cells. And deep learning approach has been used with specific Gleason grading have been achieved in prostate cancer. PAPs, using PAPNet. PAPNet is also a neural networking AI system. Then is for in breast cancer to count the mitotic figures, uh, quantification of positive tumor cells in IHC, and for checking you can do quality control. Now this feature extraction is a new terminology, and it's a medical AI connected to pathology reports. Basically, you can give your diagnosis, and the text comes out according to the diagnosis that you give. Next is the recent updates. There's a virtual pathology institute which has been created in Germany. There's a telepathology forum, which is your medical electronic consultation expert system, which is launched. And these are all your associations, which is your Digital Pathology Association, International Academy of Digital Pathology, European Congress, and European Congress on Telepathology, and International Congress on Virtual Microscopy. Now, there's a new program, which is a digital certificate program, which is launched by Digital Pathology Association. So you can get your certificate from this. For non-members, it is $499, and for members, it is $499, and for non-members, it is $599. And the membership to Digital Pathology Association is free for residents, fellows, and PhD graduates. Next, going on to the future outlook. Right now, all hospitals are moving towards becoming a paperless hospital. So it's possible to get this new concept, which is cradle to grave electronic medical data of the patient. So each patient's, right from birth to death, his entire medical data will be stored in electronic system. Next is we could have pathology reports with QR code in them. So the patient can just scan those QR codes, and they can view their slides even if they move to a different state or different country, or even after 10 years they have access to their own slides. We can use this in tumor prognostication, and a good collaboration between pathologists and AI scientists is required, because AI scientists are very good at making software, but knowledge of morphology and is with pathologists. So what we want, we need to collaborate more with AI scientists. These are my references.